PM Medical is very excited to host our guest from the Mount Sinai Post Acute COVID Syndrome Clinic. I'm Betsy Page. I serve as the Master Clinician for PM Medical. I am an SLP by discipline. I have been working in the medical setting for 16 years. I'm joined today by PM Medical's Chief Scientist, Dr. Nina Balsic. Dr. Balsic is a geneticist with a track record working in fertility, immunology, and oncology, and has been appointed research collaborator at the Mayo Clinic in Minnesota. We are pleased to introduce to you Dr. Jenna Tosto Mancuso. Dr. Tosto Mancuso is a physical therapist and board-certified clinical specialist in neurologic physical therapy. Her clinical and research interests include the development of novel rehabilitation approaches and technology in the care of individuals following neurological injury. She serves as the clinical lead of Mount Sinai's Hospital's Post Acute COVID Syndrome Physical Therapy Program. Dr. Laura Tabikoff. Dr. Tabikoff specializes in rehabilitation medicine. As a postdoctoral fellow, she investigates the pragmatic implementation and efficacy of health tech initiatives for chronic pain. At the Mount Sinai Post Acute COVID Syndrome Clinic, Dr. Tabikoff has been spearheading the analysis of clinical data to characterize and quantify impairment in long COVID. She currently serves as an active member of the AAPMR and the WHO task forces addressing rehabilitation of long COVID. And Dr. Jamie Wood. Dr. Wood is an Australian trained respiratory physiotherapist and has worked with adults with cystic fibrosis and other chronic respiratory diseases for over 14 years. Dr. Wood joined the Abilities Research Center at Mount Sinai in 2020, and his current research focuses on the development and testing of novel solutions for people with chronic disease and disability. Dr. Wood has also been assisting in the coordination of clinical research programs for people with post-acute COVID-19 syndrome. I think we're all excited to jump right in. So let's start by clarifying the terms. We have P.A.C., long COVID, P.A.C.S. What's the difference, Laura?
Thank you so much for having me. So that is a really great and important question. There's a lot of confusion regarding these terms, and the nomenclature keeps changing. So PASC, which stands for Post-Acute Sequelae of COVID-19, was described by the NIH, and it serves as an umbrella term referring to all possible consequences of COVID-19, regardless of severity of the acute illness. So it would include post-intensive care syndrome for people who went to the ICU. It also includes pulmonary fibrosis, myocarditis, and other well-defined medical conditions after COVID. So long COVID and post-acute COVID syndrome, PA.C.S, both refer to symptoms persisting at least 4 weeks after initial infection. And these symptoms can be highly debilitating and long-lasting, and they often occur in the absence of severe acute infection, pre-existing conditions, or a well-defined medical cause. So these are the main terms that are being used right now.
So can I just clarify this, Laura? Thank you. So long COVID and PA.C.S are the same thing, or is there a slight difference between them?
So long COVID was initially a term developed by the patient groups, and okay. It would be the same thing as we call PA.C.S at Mount Sinai, yes.
Great, thanks for clarifying that. So what are the typical symptoms or body system presentations of somebody with PA.C.S? Jenna, could I ask you that?
Make sure I'm unmuted there. Absolutely. So I think it's really important to identify the fact that individuals with PA.C.S can experience a myriad of symptoms. They may include all of, but it may be some of the following. Most commonly, we are seeing individuals experiencing fatigue significantly out of proportion to exertion, oftentimes called post-exertional malaise. We also are seeing post-exertional symptom exacerbation. So an individual may, in the moment of activity, and this can include functional activities, activities of daily living, or more intensive activities, experience symptom onset, not during the activity, but thereby after. Individuals are also reporting tachycardia, chest pain, intermittent dizziness, full body tingling or change in sensory pathways or patterns as, again, throughout their entire body. Those are the primary symptoms that we're seeing in most of our patients.
Thank you very much, Jenna. You are seeing patients at your clinics with the PACS patients that you see. What are the demographics? How long have they had COVID for? Do they have anything else in common? Are they vaccinated? Are they unvaccinated? Can you talk about this a little bit, Jamie, please?
Yes, absolutely, Nina. So we have a large clinical cohort of people with PACS, as well as people who are enrolled in some of our studies, including a major prospective study. And the demographics are quite similar across the board. So the median age is around 45 years, so relatively young. And then we have a range of young adults through to some people in their 70s and 80s. And interestingly, the majority have little major medical history. Around 2/3 are female and most are white. Our physical therapists have seen children, but we're predominantly an adult center, so we mostly deal with adults. And some of the key things that we see are in regard to acute infection, only 10 to 15% were hospitalized initially. But we also know that hospitalization isn't a great surrogate given the difficulty accessing care earlier in the pandemic for people. But also anecdotally, many of these people tell us in the clinic that they felt that their initial infection was mild or less severe. However, the ongoing symptoms they're experiencing are very debilitating. As Jenna said, we see a lot of people with fatigue, brain fog, headache, memory issues, cardiac symptoms, dizziness, sleep disturbances, and shortness of breath, which are the main ones. And from our data, over 80% do report that post-exertional symptom exacerbation or malaise. And then interestingly, I know we were discussing vaccination and going back to our cohort, around 70% of people with PACS have been vaccinated since having their infection. And while the anecdotal reports of the impact of the vaccine have been mixed, I do know that there was the French study published last week, which highlighted that vaccination subsequently reduced the number of symptoms by a small amount, which was 2 symptoms, but also seemed to increase the rate of complete recovery in people with PACS or long COVID, around approximately 16% versus 7% in those that were unvaccinated. So, you know, while there's emerging evidence that people with long COVID can have benefits post-vaccination, there still seems to be a lot of work that needs to be done in this area.
And I guess we don't know yet whether a third booster will do anything for those that have PACS and have already been vaccinated, do we? That's
sure, yeah, I think this is all to come in the next 6 to 12 months.
Yeah, thank you.
I know a lot of people are asking what treatments are currently being offered, and specifically with this question, like non-therapy treatments. Laura, what would you say for that?
Of course, great question. So our management approach for PACS focuses on creating a holistic patient safety net. So our rehabilitation program will start with a medical evaluation by a cardiologist or a physiatrist to determine the rehabilitation needs of the patient. Then patients will undergo a cardiac clearance where they are screened for underlying cardiopulmonary pathologies, including myocarditis and lung fibrosis. We typically will start here with an echo and an EKG, and more complex tests such as MRIs and Holters and stress tests are used for very particular cases. So we also screen here for dysautonomia. So we use an active stent test for that. And after cardiac clearance and evaluation, patients will typically start our autonomic conditioning therapy program developed by Dr. Tasso Mancuso. And from a medical standpoint, our approach here is to make sure that patients are referred to the appropriate care they need. So that would include medical specialties, including neurology or ENT or gastroenterology, and to our complementary approach team, which includes psychology, acupuncture, craniosacral therapy, yoga, and others. Most importantly, we focus on autonomic regulation, so providing information about symptom management and energy conservation and pacing strategies. We also prescribed electrolyte supplementation, optimized fluid intake, and prescribe compression garments for some cases. Our providers do not typically prescribe specific medications for dysautonomia in our program, but rather we focus on managing the current medication lists to make sure that nothing in there can be worsening symptoms. We are also implementing and trying out novel cognitive rehabilitation strategies focusing on cognitive rehabilitation.
That is quite extensive and exciting to hear about. I see one question, just briefly, what does the autonomic testing look like?
So it's an active stent test. There are other forms to quantify dysautonomia, like the tilt table test, but there's limited availability for that sort of testing. So the active stent test just requires a clinician and measurement of heart rate, blood pressure, and pulse oximetry according to the patient position.
Very good. So the other side of that question is for Jenna. Can you describe the physical therapy protocols that you've implemented? How do you assess readiness to enroll? And then how are people with PACS responding?
Absolutely. And I think this has become a really important area for the practice of rehabilitation, primarily physical therapy, largely because the autonomic conditioning therapy paradigm is quite different than perhaps what many therapists are used to prescribing for exercise. And so I guess to start from the beginning, evaluating for preparedness and appropriateness. So as Dr. Tabakov had mentioned, number one, getting that medical evaluation and making sure that any clinical red flags have been ruled out. The appropriateness and readiness for rehabilitation, specifically for physical therapy, largely is collaborative between the referring physician and our team on the physical therapy end. We do like to start our patients with breathwork coaching. So patients generally will begin with about 4 weeks of breathwork coaching. The idea behind the breathwork component is multifactorial in that, number one, it focuses on breathing mechanics. It focuses on nasal breathing, the management of CO2 and O2 for patients who perhaps are in a hyperventilatory state and thereby hypocapnic. So focusing on that first. And we're finding that starting with breath work is a nice introduction to rehabilitation, largely because it starts to build a bit of symptom stability. And so ultimately, in the prescription of exercise for individuals with long COVID or PA.C.S, gaining symptom stabilization is indeed the priority. So once patients have gone through breathwork coaching, they can begin rehabilitation or physical therapy. Our group has in service and upskilled close to 200 physical therapy clinics, both in our area and nationwide, just to start to spread a bit more education. And so to give some context to the program itself, it is a 3-phased program. Phase 1 of the program begins individuals in supine. All of the interventions or movements are supine active range of motion activities. I should really highlight that the key to all phases, specifically at phase 1, but all phases, is symptom titrated progression or symptom titrated exercise. The idea that using traditional principles of exercise prescription, for which intensity is the prime mover, I really need to stress that that's not the case for this, but instead really listening to patient symptom report and symptom exacerbation. As I had mentioned earlier, it's not uncommon for a patient in session to feel okay, and then after the fact start to experience that post-exertional symptom exacerbation or post-exertional malaise. So again, phase 1 of the program, patients are starting with very basic supine-based active range of motion activities. Generally, they start with 2 to 3 to begin with and are progressed from there. In phase 1 of the program, the goal is to progress from supine to upright, really taking into consideration this autonomic nervous system adaptation to activity. Obviously, contending with gravity in the upright can be provocative of symptoms. So starting from supine to upright. In phase 2 of the program, as patients are tolerating well, we move to overground walking intervals that again are symptom titrated. We put a really heavy emphasis on the use of rate of perceived exertion or RPE. The Borg scale is really quite pivotal for starting to get a better understanding of energy windows and energy conservation strategies for folks who are really experiencing that post-exertional symptom exacerbation. And so again, we're moving through phase 2 in those walking intervals. Phase 3 of the program is to get patients started on the Levine protocol. The Levine protocol was originally designed for individuals with POTS or more traditional dysautonomia. But we found rather quickly that the Levine protocol was not well tolerated by patients. And I should point out that the Levine protocol is oftentimes called the Dallas protocol. It's oftentimes interpreted as the CHOP protocol. There are a few different variations, but just for clarity, we're really talking about the same idea. The idea behind the Levine protocol is more of a graded program of aerobic exercise. So it is a bit more intensive. And as I was saying, we found very quickly that that form of intensive exercise was absolutely not tolerated by patients. And it really goes to show that this idea of symptom titration and I say this, I feel like every time, but the physical therapy mantra of one more repetition and really push, push, push does not apply here. So that is the overview of the physical therapy program.
Thank you very much for that, Jenna. It appears that many patients present with shortness of breath or breathing discomfort. Do you find this in your patients? And where does this come from? Jamie, could you answer that?
Thanks, Nina. This is a really interesting topic to explore and something that I'm very passionate about with my background. And I think it's very important given that over half of the people that we see do report some type of shortness of breath. And taking a step back, given the relatively young age of this cohort and the fact that most had no major medical history, it would seem possible that this could be the first time that many of them have experienced shortness of breath related to a medical illness. So it's a very new thing. Shortness of breath is a sensation. It can be very subjective as to what the person's feeling. So as clinicians, it's extremely important to determine the cause before offering any targeted treatments and advice. And in general, for people with the dysautonomia-like symptoms, the shortness of breath experience will be different to what physical therapists would observe in, for example, someone with a chronic lung disease like COPD. And the group of patients that may have a more classical shortness of breath post-COVID are probably the ones that had severe lung insults, ended up in critical care, intensive care, and have developed significant lung disease since. But given that this isn't the profile of our PACS cohort, we do need to dig much deeper into other causes. And while there may be some exercise-induced shortness of breath stemming from reduced activity, but again, most of the people that we see tell us that they can still do these activities. They can exercise, but the problem and the caveat is that will lead to post-exertional symptom exacerbation and malaise. So I'm just not convinced that most of the people with true PACS have this classical shortness of breath. So that leads us down to looking at other things like dysfunctional breathing patterns, which includes hyperventilation syndrome, which can often be subtle and difficult to diagnose. People with hyperventilation syndrome can breathe very shallow and rapidly, and then often feel like they can't get a deep breath in, or they need to take deep breaths occasionally, or even sigh or yawn. And the sensation of shortness of breath may also be related to other symptoms of things like chest discomfort or heaviness, tachycardia and palpitations, and even dizziness. And these can all be intricately linked together in this dysautonomia-like pattern. Another major cause to consider is vocal cord dysfunction, which I think a lot of people are missing and will often be associated with sudden onset gasping or shortness of breath on activity or exercise. People may feel tight or wheezy with their breathing, often talk about they feel like they're breathing through a straw, as well as things like coughing, hoarseness, and excessive throat clearing. So if VCD is suspected, then the best thing to do is to refer on to an experienced speech therapist or even an ENT physician or both in a clinic. And I think the important message is for the clinicians watching today that shortness of breath in post-acute COVID syndrome is a great example of why it's important to assess and treat the person's presentation as opposed to treating the label of a condition, because there can be several ways that this can play out accordingly.
There's still so much to explore and so much to find out. What research programs are you running at your clinic at the moment, Laura?
Yes, I'm so glad you asked about this. So as part of our research programs for PACS at the moment, we are investigating both the clinical effects of our rehabilitation program, as well as the physiological mechanisms and potential biomarkers for PACS. So as part of our PACS biomarker pipeline, we have an ongoing collaboration with Professor Akiko Ifasaki from Yale Medical School. And in this project, we are analyzing blood samples from 100 PA.C.S patients and comparing these findings with control groups to potentially find immunological signatures of PA.C.S. So one of our hypotheses here is that long COVID can be a result of an autoimmune reaction triggered by the virus. Our preliminary results are really striking, and we hope to be able to share them with you soon. We are also investigating cardiac morphology. So we are performing PET-MRI testing and comparing it with symptom severity data and patient-reported outcomes. And the ultimate goal of all our research program here is to inform rehabilitation and new treatment strategies and ultimately improve patient care.
Excellent. I have a question for Jenna. What advice would you give clinicians and clinics regarding how to formulate an appropriate and holistic care for someone with PA.C.S, including, are there certain trainings? I know the autonomic dysregulation is something that is gaining a lot of focus right now with post-COVID. What kind of recommendations do you have for therapists?
Sure. I think the first piece of recommendation and first piece of advice that I think is pivotal, and I had mentioned this earlier, is the care of individuals with long COVID needs to be both holistic and patient-centered. And that's not to say that's not the case in all diagnoses. But I think now more than ever, we really need to listen to our patients because our treatment plans and paradigms are quite different in this case than perhaps what we are used to, regardless of the area of practice for which you generally specialize in, especially because of the necessity of symptom titration and the need to really think about how we're progressing without getting caught up in the idea that pushing too hard or pushing hard in general will somehow make the patient's symptoms better. This is non-traditional in that sense. So my first piece of advice is to really listen to your patients, hear what they are saying, hear what they are reporting, and start to formulate your plan of action around that mantra. In terms of training, I think it may have been mentioned earlier. I think right now, some of the incredible resources that are starting to come out specifically geared toward physical therapists can be a great place to start. So World Physio recently put out a briefing paper making recommendations for the rehabilitation care of individuals after or with long COVID. I'm proud to say that all of us on this call were members and contributing members of that briefing paper. And so I think that the recommendations made there are really, really important for therapists who are seeing this population to have a great read of that, take into consideration. Our group, again, is hopefully continuing to put out our publications as Dr. Tabikoff and Dr. Wood are tirelessly working on the data. So really look to those references and feel free to look to groups such as ours for advice. We like to be really transparent about our treatment approaches. And so always looking for community, because just as our patients have really done an incredible job of building community support, I think we as providers also should be looking to our communities to start to learn, because this is a diagnosis that none of us have seen before. So I think those are really good places to start.
So just linked with that, I'm seeing questions pop up. Is there a website or a way that they can find your clinic or resources? And I saw the World Physio paper just put in there. But do you have any specific guidance for that?
Sure. So I can see, I apologize, I am not with my laptop right now, but I can throw in the chat or get out the resources for our website for just a little bit more context. Our Mount Sinai website through the Abilities Research Center, we should have some information on post-COVID there. And additionally, as resources become available, as our publications become available, we absolutely would be happy to share. And at the end of the day, feel free to reach out to any of us individually. We've done quite a few podcasts, and we do have some pre-recorded materials that we'd be happy to share with the community.
So I'm just going to throw out there, do a good old internet search for any of your names. One last question for you, Jenna. How long is the expected recovery?
So, oh, there you go. I see Dr. Tabakov just posted in there. Thank you. In terms of expected recovery, I will say the duration is quite longer. There is no standard right now, biomarker of standard for recovery. We have patients who have been in our program for as few as several weeks, spanning all the way through several months. The minimum at this point that our data is showing is 90 days. So a minimum of 90 days in therapy, which I think is on the lower end. I think we'll see for some sort of more concrete recovery marker. My instinct is it will likely be longer. And with that said, I think that's all the more reason that those of us in healthcare and providers need to advocate for our patients, particularly to our governing bodies and for reimbursement and insurance purposes, because I think that this is going to be something that takes a bit longer for recovery.
Is a complete recovery expected in most patients, or?
It's difficult to say right now. We're continuing to see our data progress. So it's difficult to say right now, but I am optimistic that as we continue to look at the data more closely, anecdotally, we can speak and say that, yes, we have patients who are getting better and returning to their day-to-day lives, which as providers is always the goal and always something that makes us really excited for the progress. But I am looking forward to the more concrete data to give that answer.
Awesome. And Jamie, we definitely want to ask this question because it's the one I get the most. What about respiratory muscle training in this group? Is it, is there a difference between P.A.S.C. and P.A.C.S., or is there a certain time frame or presentation we're looking for?
This is a great question, Betsy, and I know that something we've discussed before, and I've had experience in respiratory muscle training in different cohorts of patients, and I think it needs to be thought of as another tool that the clinician can have in their bag for treatment. As with most things with post-COVID, there's not one size fits all. And so there's some emerging evidence from studies where people have done it in PASC, so mostly people that have been very unwell in intensive care, who'll be very weak in terms of their respiratory muscles. And then we've got the other end of the spectrum, which is the P.A.C.S patients. And so while I am definitely an advocate for it in the right patients in the P.A.C.S cohort, we definitely need to be mindful of causing symptom exacerbation in people with true dysautonomia like P.A.C.S. And so Jenna and I have tried RMT in a number of patients. We've pretty much had a perfectly split mix of people who loved it and then people who used it once or twice and felt that their chest respiratory-like symptoms were exacerbated. And I don't believe that it's the treatment itself that causes that. It's the activity associated with doing the treatment. So it could have been an airway clearance device, or it could have been playing a musical instrument or something would have done the same thing. So the patients that loved it went through a whole program according to their symptoms and completed it, and generally they tracked as doing very well across the board, whereas perhaps the people that felt they didn't like it so much, we introduced it too early and they should have been focusing on more of the autonomic conditioning rehab before even considering that. So I think, again, it's a bit of trial and error, clinician judgment, and, most importantly, patient preference and feedback at this point.
Thank you, Jamie. I think in the interest of time, we'll have to wrap it up. Betsy, what do you think?
Yes, thank you everyone who joined. And I know there were a lot of questions, but again, please just reach out. We're so excited to have you guys today.
Yeah, thank you so much, Dr. Laura Tabakov, Dr. Jamie Wood, Dr. Jenna Toster-Mancuso. It was a real pleasure to have you here. It was a very exciting webinar, I think.